Hello, everyone. It's so good to be with you. I'm recording this on November 10th, I believe. I believe it's the 10th. Yeah, November 10th at 6 p.m. And so I am happy to be here with you. Dr. Fryer, thank you for the invitation to do this lecture once again for the phenomenal students at the University of Maryland. My name is Dr. Christopher King, and I'm an alum. I completed my PhD in Health Systems Administration in 2013 and Health Services Administration in 2013. And my focus was um, on vulnerable populations, minority health, health disparities, racial disparities, and cancer. So it's a pleasure to be back and to give back and help shape the future of folks who will lead in public health or in healthcare delivery or in different capacities to improve the health of the nation. So the title of this session is the role of the ACA, the Affordable Care Act, and the uninsured and minority health. I've provided a few overarching objectives. I want to be sure that we examine the state of the United States healthcare delivery system and what things looked like before the Affordable Care Act in 2010. We'll also break down different components of the ACA. We'll define access and what access to care really means and how it ties to health outcomes. We'll look at some of the provisions in the Affordable Care Act around access. And then we'll think about, what's next and what's happening in the world right now, especially as we are dealing with COVID and the escalating rates of COVID infections. What does that mean? And what happens if the Affordable Care Act is repealed? I don't think that's going to happen, but it's worth the conversation. So here you can see the breakdown of race and ethnicity. On the left-hand side, you'll see 2010, and you can see the dark blue represents white, non-Hispanic residents, residents. And then 16% represents, Hispanic, 12% Black. Again, this is 2010. And then in 2050, you can see the predicted change based on what's happening in the world right now, right? So you'll see that the white population is predicted to shrink, but we'll see growth in the Hispanic population and the Black non-Hispanic is predicted to remain relatively stable. So that's important to think about. I want to be sure that you have that because I'm going to share some disparities data with you. And as we think about what the future is going to look like, this just really drives home the case for why it's so important that we address racial differences in health outcomes. And the Affordable Care Act has played a significant role in getting us there. We're not completely there yet, but the Affordable Care Act has certainly helped us. So a quiz for you. I want you to think about this. How much do you think the United States is spending on healthcare annually? I'll give you just a few seconds to think about that. All right, so if you said 1 billion, if you said 330 million, if you said 700 trillion, you are incorrect. We're actually spending approximately $3.5 trillion on healthcare in this country. So that figure probably doesn't mean anything to you without having context, right? So let me give you context. So what you can see here is these are countries, these are peer countries, right? And the vertical axis represents life expectancy. So 65 to 85 up here, right? And then the horizontal axis represents how much we're spending per capita, all right? And so you can see here we are, aren't we special? The United States, we are literally almost off the charts. We're spending a heck of a lot per capita, right? And we're not living as long when you look at our life expectancy compared to other countries. So obviously we're doing something wrong, right? There's something that we just are not getting right. And that's why I'm excited to talk to you, because we need new folks actually helping us think differently, excuse me, about how to deliver, how to organize systems that excuse me. Oh gosh. Mm. I hope that isn't recording. If it is, you can laugh. Oh gosh, that has never happened to me before. Ugh, not good. All right, I think I'm ready. Sorry, I just had a coughing spell. So, um, so you can see that we're spending a lot more, and we're not living as long. There's a problem. That's a problem, and disparities is a significant contributor to why we're spending so much and why we're not living as long as people who reside in peer countries. So before the Affordable Care Act, I just want to give you a picture of what how we looked. And I'm going to focus on what's in red. We had a lot of people who just did not have health insurance, approximately 40 million people. We had a lot of folks who were denied coverage because they had a pre-existing condition. So this means, let's say that you had a job, you had health insurance coverage, you're a person with diabetes, you get an opportunity to work somewhere else, you get a job offer somewhere else, you go, and you can be denied coverage with your new employer's insurance policy. And so that's not good, right? I mean, that's just cruel. And so that needed to be addressed. Um, Here, coverage gaps for younger populations. So many of you are under the age of 26 because of the ACA. You can still be on your parents' health insurance. You can still be covered under your parents' policy. And then here, traditionally medically centered model of care focuses on just that we've been delivering care based on, you know, our biology and not really focusing on the social and environmental factors that contribute to our health. Right. So we can provide the best clinical care within the walls of our institutions. But if people are going home into communities, or they reside in communities that just do not have the infrastructure for healthy living and well-being, they're going to end up back in our clinics and hospitals. And then obviously health status of the United States population is worse than peer countries. These are three documentaries that I would recommend if you're interested in learning a little bit more about our healthcare system and the inherent flaws that exist within our system. Sicko, it's a Michael Moore a documentary. And then there's Escape Fire and Unnatural Causes is a great series that speaks to the social and environmental conditions and how those conditions really do make us sick, particularly those who are vulnerable or are underserved or folks who lived in historically marginalized population or communities. So what do you know about the Affordable Care Act? If we were all together, I would stop and I would ask you to tell me, what do you know, so I can get some sense of where people are with the ACA. There are three overarching goals of the ACA. One is to increase access to health insurance coverage, right? Two is to protect patients from arbitrary actions imposed by insurance companies, such as aggressive billing practices. And then three is to improve the quality and reduce healthcare costs. So if you're looking at the news, most of the time when you hear about the Affordable Care Act, what you hear about is Medicaid, 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 and you may hear a little bit about pre-existing conditions, right? But there's so much more in that legislation that doesn't really get the recognition that it deserves in mainstream media. And you will be exposed to all of the details in the legislation, so that you can have a much more informed conversation with your peers, with potentially your employer, with just lay people on the streets about the Affordable Care Act. Um, so I'm going to do that, but I want to also be sure that we understand what access means, because a lot of times we think that access is really about having an insurance card, right? You have an insurance card, okay, you have access to care. That's not always the case, right? So, for example, in the District of Columbia, 96% of adults have health insurance coverage, but we have some of the most stark racial disparities in health status and health outcomes that exist in the country, right? And so, when I'm talking to people about, how sick so many folks, literally how sick people are who live in our nation's capital, and I tell folks that just about all those people have health insurance. I'll get a quizzical look like, well, what's going on? They have access to health care. And I'm like, okay, just because you have an insurance card doesn't mean that you're going to get the right care at the right time and in the right place. And it doesn't mean that you're going to get the same quality of care and the treatment and the communication that others may have based on who they are, right? And so that's a very complicated dynamic that really feeds into our definition of access. It goes beyond just having an insurance card. So, access to health services means timely use of personal health services to achieve the best health outcomes. So, you have to gain entry into the system. The insurance card does that. You have to access a healthcare location where services are provided. That needs to be accessible to you, it needs to be convenient to you, right? And you have to find a provider with whom you can communicate and you trust. And sometimes that's a barrier for people. And so if they have a provider that really they're not connecting with the provider, they don't trust the provider, there's some psychological hang up, that is a barrier to access. Okay. So think beyond just having an insurance card. There's a lot more that we have to consider when we're talking about access to care. Here's a framework for you. With Penchansky and Thomas did some groundwork in 1981 on access and the dimensions of access. And so what you see here are the 5 dimensions of access. First, availability. Are services available? Are they accessible to you? Can they accommodate your needs? For example, if you're a person that doesn't speak English as a primary language, does the staff, does the clinician speak? Uh, are there bilingual services available to you so that there's no gap language barriers? Can you afford the services? Right, just because you have insurance, you may have insurance, but you may also have co-payments that you have to pay. Is that affordable to you for you? Acceptability. This goes to your own personal preferences, right? Let's say that you are LGBTQ, or you have some type of personal nuance that really isn't a big part of you, right? You need to be with a provider that respects that, and a provider who can, communicate with you in a very effective way. So these are the dimensions of access that must be considered if we're trying to increase access to care for people. We also know that health insurance is linked to quality of life, right? And preventing the development of chronic disease conditions. Uninsured persons are more likely, or excuse me, less likely to receive medical care. They're more likely to die early, and they're more likely to have poor health outcomes. A lot of times when people don't have health insurance, they obviously don't go to the doctor. And when they do, it's probably through the ER, and that's when they get some type of diagnosis that they have diabetes or they have heart disease or they have cancer. But the condition could have been either prevented or uh, remedied or treated better had they engaged with their provider earlier in their life. So that's why access is so important. And again, getting the right care at the right time and at the right place. So let's look at the Affordable Care Act and some of the provisions in the ACA. I'm going to talk a lot about Medicare and Medicaid, and I want to be sure that I level set. It's important for you to know the difference between Medicare and Medicaid. And if you already know, I apologize. I don't mean to insult your intelligence, but I know everyone does not know the difference between Medicare and Medicaid. Okay. So Medicare is a federal insurance program, right? And it is designed for people who are 65 and older, and it has it pays about 80% of healthcare costs. So imagine a pizza, you know, and 80% of that pizza is represents services that uh, that Medicare will pay for. The 20% are the patient is responsible for the 20%. So Medicare does not cover 100% of your doctor's visit. It covers 80%, and then you are responsible for the other 20%. And that would apply for if you got some, for having some type of medical procedure, some type of surgical procedure. Medicare pays 80%, you pay 20%. Now, you could be a dual eligible, meaning that you have Medicare and Medicaid. Medicaid, on the other hand, is designed for people who have low incomes, right? Low incomes, it's not restricted to people ages 65 and older, adults with low incomes. And so you see it covers dental and vision services. Participants pay very little when it comes to sharing the cost of their care, because Medicaid, you have to be low income in order to qualify for Medicaid. All right. So a dual eligible, those are the folks who fall in the middle. So they can have both Medicaid and Medicare. And you see that with that comes prescription drug coverage, outpatient hospital care, inpatient hospital care. Also, I should note that persons with disabilities can have both Medicare and Medicaid. Okay, so I hope that makes it clear to you. So Medicaid is a state-based program. Medicare is federal. Okay, and all of this is facilitated through CMS, the Centers for Medicare and Medicaid Services. So how does the ACA increase access? Well, one, it expanded Medicaid, meaning that the threshold for actually qualifying for Medicaid actually was lower, right? And so, or higher, depending on how you look at it. So it's easier to receive Medicaid based on your income up to a certain level. So it's more generous in the formula for who qualifies for Medicaid. So that's one thing the ACA did for us. Insurance exchanges to help small businesses and those who are self-employed. So if you are a sole proprietor and you had your own private health insurance plan, it could cost you lots of money, like maybe $1,000, $2,000, $3,000 a month. That's really, really expensive. And so, so now there's these plans that are available for folks who are sole proprietors or they have small businesses, because small businesses also are having a difficult time having policies that were affordable for their employees. And so these exchanges actually address that. guaranteed coverage for pre-existing conditions. So remember, I was telling you about the person who has diabetes, and if they get another job, then they could be denied coverage. Well, the ACA makes that illegal. You can't be denied coverage because of a pre-existing condition. Coverage for persons up to age 26, I've already talked about that. And then minimum coverage provisions to reduce uninsured rates. And so that was referred to as the, oh my goodness, it'll come to me in a minute. But when the ACA was rolled out, it was mandated that everyone has to have some type of coverage. Otherwise, you pay penalties. The mandate, the individual mandate, that's what it's called. So you'll hear people talk about the individual mandate and how illegal that is to require people to have health insurance, right? And so that was what the Trump administration used as a vehicle for all this ammunition around repealing the Affordable Care Act. How dare you tell people that they have to have insurance coverage, which I don't understand that personally, because when I drive my vehicle, I have to have insurance. If I don't, I'm doing something that's illegal, right? And so how about I have some type of coverage to protect my body and my health and my well-being? So it just doesn't make sense, but you have people who think that that is too much control at the government level, and that people should have more freedom when it comes to if they choose to be covered or not. So this slide breaks it down for you. So you can see the two big buckets of the ACA: insurance reform on the left-hand side, and then health system reform on the right-hand side. And so under insurance reform, you'll see more people covered, right? And those are the pieces I just talked to you about: Medicaid expansion, the exchanges, people under 20, kids or teens or young adults under the age of 26 are covered, right? That's the column that gets the most attention in mainstream media. But look at all the other pieces of the Affordable Care Act that people just aren't aware of. And I think if more folks understood how comprehensive this legislation is, they will be less likely to, they'll be less vocal when it comes to repealing it. So you have all of these protections, and then efforts to lower the cost of healthcare. And in addition to health system reform, that I represent the hospital industry in my work, right? The ACA has really, really pushed us to do better in our efforts to improve the quality of care that patients are receiving. And there's incentives that are built into the ACA so that, you know, if we are delivering care at the right time and we're seeing really good patient outcomes, then we will be financially incentivized for that. Again, this is thanks to the ACA. There's the legislation also includes components around workforce infrastructure when it comes to the public health professionals. There's all kinds of initiatives built in to improve the capacity of the workforce when it comes to addressing health disparities and meeting the needs of our most vulnerable brothers and sisters, right? And then there's another pillar that focuses on public health prevention and transformation grants and community health needs assessments. Every hospital has to do a community health needs assessment once every 3 years. Not only do they have to do the community health needs assessment, they have to develop an implementation strategy on how they're going to address an issue that is a priority for the communities that they are serving. So that's a whole nother body of work. Anyway, this legislation is making a big difference in improving health, addressing the needs of historically marginalized populations, addressing racial disparities, improving public health, enhancing the workforce as a means to do that, and lowering cost of care, and ensuring that we have hospitals and health systems that are delivering care based on the evidence, because we know when care is delivered based on the evidence, we will see improvements in the health of individuals and populations. So it's very comprehensive legislation. And I keep coughing. Okay. It's very comprehensive legislation, and this is your cheat sheet. And then here you have the annotated version of the document that I just shared with you. So it describes each one of those buckets that you see here. So Medicaid expansion is a big, big deal. And I just pulled this slide just a few minutes ago because every year we have a state that expands Medicaid, but you can see the light blue represents the states that have expanded Medicaid, meaning that they have changed the threshold in which one would be eligible for Medicare. All right. And so if you're interested in knowing what that is, you can just Google it and you can see it's based on federal poverty level and what percentage of your income is above the federal poverty level. So those states are blue, light blue, adopted Medicaid expansion, or they passed Medicaid expansion, and the dark blue, those states have not expanded Medicaid. Now, one thing that you can do is you can overlay this with red and blue states, and you'll see some trends. You can also overlay this with communities that have higher ratios or higher volumes of people who are Black or Hispanic, and you'll see some trends there, right? So this never happens. I mean, I always record lectures and I've never had a coughing spell. Okay, so why are some states not expanding Medicaid is probably what you are wondering. And many of the leaders of these states will tell you that it's going to be too expensive. So when this was first rolled out, the federal government actually made a financial contribution to help these states with increasing their capacity when it came to Medicaid, because they needed support. They needed financial support because thousands and thousands of people were coming into the healthcare system that just weren't present. But those dollars were only temporary. And after I think 2 or 3 years, it's going to be up to the states to fully fund their Medicaid programs. And so these blue states are like, I don't know, this is going to be really, really expensive. It sounds attractive in the beginning because we'll get these dollars from the federal government, but those are short-lived. They're short-term dollars, and we will have to be responsible for covering all of these new people, many of them sick, by the way, who need care. And so they have chosen not to expand Medicaid. However, when you look at these states, many of them, especially this section here, the southeastern quarter, you have lots of people who are just not healthy. There's obesity issues, there's diabetes, there's hypertension, and it's sad, right, that you have so many people who need services that those services just aren't available for them. So where are we now? This is a timeline, so you can see 2008 all the way up until 2018. And you see here, we were at a peak of approximately 18% of adults who were uninsured. Now, the ACA was rolled out in was enacted in 2010, but it takes time to actually see the benefit. And here you can see that we went from 18% down to a low 11%. Again, thanks to all of the Medicaid, not just the Medicaid expansion, but the other pieces I was telling you about, the insurance exchanges, and all these different opportunities for people to obtain coverage. So that's something to celebrate, right? Yeah, and I'll give you, in just a few minutes, I'll show you what populations actually benefited from this. So you can see here, and then what happened, we had the Trump administration, and remember the repealing the ACA was a big part of the conversation, and then eliminating this individual mandate. Remember, that's when I was telling you that people be fined if they did not have an insurance policy. So, so that's why we're seeing more people. This is why we're seeing the trend move up, and why more and more people are becoming uninsured. And of course, if the Affordable Care Act is repealed, we will easily go back up to the 18-20% of Americans without insurance coverage. And that would be really, really traumatic for this country for several reasons. One, we are in the midst of a pandemic, and so many people are becoming infected with coronavirus, and those people need health care, right? So you just imagine if they don't have insurance. Also, if they have coronavirus and they have some type of condition that develops as a result of coronavirus. Coronavirus is still new to us. We don't know the long-term effects of it. They could have some type of condition that will not be covered because it's a pre-existing condition. So that's why this is so dangerous. The whole discussion around repealing the Affordable Care Act and not having anything to replace it, which just, there's nothing that this administration has to replace the Affordable Care Act. However, there is so much ammunition and motivation to repeal it by the administration. So I don't want to digress with that, but it really does. It really is a problem, and it's something all of us should be passionate about addressing. Now, is the Affordable Care Act perfect? It's not. It's not perfect. There are issues with the Affordable Care Act, but it's a heck of a lot better than where we were prior to 2010. What needs to be done, from my professional opinion, is to continue to improve the Affordable Care Act. Don't repeal it. All right. You improve it, you address the issues. One issue is the high premiums that some families have to pay. We need to figure out how to address that. Or some of the co-payments may be high for certain policies. We need to figure out how to address that. But just stripping people, 20 million people, from coverage is, to me, unethical, it's immoral, and it's just not the American thing to do. So here you can see the distribution of health insurance coverage. Most people have insurance through their employer, right? And their employer shares the cost of their policy. And so you can see that we're around 50% of people are covered through their employer. This line here represents, what is this? Line here represents persons who have Medicaid, right? Medicaid. And then this line here represents the uninsured. Make sure I have this right. Okay, so oh, okay. So other public insurance, which is what this represents here. Some states have programs that they sponsor. For example, in the District of Columbia, we have a safety net program that's exclusive to DC residents who, for whatever reason, they're not eligible for Medicaid, they're not eligible for Medicare, and there's just nothing left for them. And so there's a safety net insurance program. A lot of states have these types of programs. So that's what other public represents. So you can see just a distribution of how people are covered. This is a powerful slide because it shows you how far we've come. So this is this is the early portion right after the Affordable Care Act was enacted, and this is 2007. So this represents the insurance uninsured percentage, right? So you can see which racial groups or ethnic groups actually benefited from the Affordable Care Act. And you'll see here that American Indians, and then you can see this dark blue here represents Hispanics. Okay, so you can see significant reductions in uninsured. This dark blue represents Blacks, the gray, Native Hispanic, Pacific Islanders, and then this is white, okay? So you can see the populations that have benefited most from the ACA. This slide shows you the non-elderly. These are folks between the ages of 18 and 65. That's what we mean by non-elderly. So who gained coverage? You can see the majority of them were men, almost 50-50, but it's 53% men. The age group that benefited the most, persons between the ages of 19 and 34. And then you have the 35 and 54 here, 55 to 64. This population benefited the most because these are folks who either were covered under their parents' policy, so they're newly insured thanks to the 26, 26 and anyone up to the age 26 can be covered. These are also folks who are just, you know, they're young and they may be working, you know, hourly. They may have a job and be paid at an hourly rate. And because of the ACA, they have access to more options. And then here you can see race and ethnicity, and you'll see that 42%, whites represented 42%, and then you'll see Blacks, Hispanic, and non-Hispanic. Again, I just want you to see the distribution of folks who gained coverage from the ACA. And then this shows states. So which states actually demonstrated the most impact when it came to going from percent of people who are non-elderly who are uninsured to those who are insured. And so the dark blue are the states that really have done a great job with insuring people who did not have insurance. Rhode Island, West Virginia, Kentucky, California, all right? And these are numbers per 1,000. So it's 155 per 1,000 of people actually gained coverage as a result of the ACA. So I want to talk a little bit about some myths. You know, a lot of times people think that if you're uninsured, that you're lazy or you're not gainfully employed. A lot of times people are gainfully employed and may not have adequate health insurance. Sometimes people are working multiple jobs and they don't have the best insurance coverage. The Affordable Care Act has provisions in place to address that. Like insurers have to cover primary care procedures, right, based on the United States Preventive Task Force recommendations. So those are evidence-based preventive measures that every American needs to have if we're going to keep that person healthy. And it starts when you're born with your vaccination, right? And if you're a woman over the age of 50, then you got to start getting those, the mammogram, for example, mammography. Men need to get prostate exams after a certain age. So at minimum, your insurer has to provide those services, thanks to the Affordable Care Act. Another myth is that a lot of uninsured people are sick. That's not always the case. You can have very healthy people who are healthy people who are not sick. Let's go back to the requirement for every American to have coverage. Remember, I was talking about the individual mandate, right? That's a matter of economics, right? If we have a lot of healthy people actually paying into the system, right? They're paying their premiums, right? They're feeding into the pool of dollars that are available for healthcare. but they're low maintenance people, they're healthy people, but they're still putting some dollars into the pool that makes things work for everybody, right? And so you may feel like, well, I don't need insurance because I'm healthy. I don't think it's very smart, first of all. But but keep in mind what you're doing is you are making sure that there's um, availability of services for you as you get older, right? And so that's the whole justification for people paying into the system when they're young, because young people are less likely to use a lot of healthcare services. They'll just use primary preventive services, annual physical every year, maybe some special checkups, but that's about it. You know, so that was a matter of just economics and really just making sure that we have dollars available to take care of the country. Uninsured persons do not use healthcare services. That is certainly a myth. A lot of times these are the folks who go to the ER, right, for something that could have been prevented or something that could be remedied through a primary care visit. And the other part that the ACA, I really think, has done a great job helping the nation come to terms with, and that's the fact that health is mostly shaped by where we live, work, eat, and play, right? It's shaped by the social and environmental conditions in which we live, the physical environment, um, economic factors, right? So the quality of education, the type of work that you have. Do you have a job that pays a minimum wage, or do you have a job that pays a livable wage? Those are very different calculations. Income, family and social support. We know that social support is a key factor, especially if we're trying to prevent readmissions, right? And support well-being. Social support is key. Community safety. Is my neighborhood safe, right? Am I stressed when I walk out the door? Am I is every decision I make a matter of life or death, right? And so that stress certainly does impact health and can lead to or stimulate the development of a chronic disease condition. So I'm going to close here, but I just want to wrap up high level, right? The Affordable Care Act was enacted in 2010. More than 20 million people in this country gained coverage. There's variability based on where you live, right? People gained coverage because of, one, Medicaid was expanded, meaning that more people were eligible and qualified for Medicaid. Insurance exchanges became available for people who were sole proprietors or small businesses, right? And so we have more people who have coverage today. We also know that a lot of people who are newly insured also have chronic disease conditions that need to be treated. So these people are in care, and that's what we want for the country. And yes, it's probably going to cost us a lot of money up front. But what's eventually going to happen is once folks are in care and their conditions are controlled, we'll see a decrease in healthcare expenses. Hope, in theory, that's what we hope. There's still a lot of states that did not expand Medicaid. A lot of these states have very, very sick residents, right? And what happens when you have people who don't have access to primary care services? They end up in the ER. The ER is a very expensive place to receive care. It's expensive because it's highly specialized and it costs a lot to operate in the ER. And so if you go to the ER for a stomach ache, you're probably going to get a bill for about $2,000 to $3,000 because it's a very expensive place to receive care. We all pay for that. So let's say someone goes to the ER, they're uninsured, they have a stomach ache, their bill costs $2,000. or the expense is $2,000, what happens? Somebody's going to pay for it, and it's probably going to be the taxpayer, right? And so it's just really important that we all support efforts to improve access to care, recognizing that access is not just about an insurance card, right? It's about, you know, can they accommodate me? Um, um, do I feel respected, right? Are they open when when I can, do they have evening hours or weekend hours? Because I work full time and I have a job. My job's not, um, it's not letting me off work, right? Me, I'll lose pay, right? And so, which that's another conversation about employers that's another lecture. Um, but we just need to be sure that we fully operationalize access and how we think about caring for people, um, to meet the needs of a very, very diverse population with different types of needs. So it's interesting that this is happening today. I'm recording this because the Supreme Court has these hearings right now around, again, the repeal of the Affordable Care Act. I don't think it will be repealed, um, because if it is, it's going to be it will be a catastrophe for the country. We're already on fire with COVID-19, and to put 20 million people in a space where they don't have insurance, and a lot of them may have been or may be infected with COVID-19, um, and they don't have insurance. That's just again unethical. It's immoral and it's un-American. And I just hope that that's not where this country ends up. I'm not going to share this video now, but you'll get the slides, and I just think it's a really interesting video. Jimmy Kimmel a few years ago talked to lay people on the streets and asked them um, if they thought that the Affordable Care Act or Obamacare needed to be repealed. And a lot of people thought they were very um, different pieces of legislation. The Obamacare and the Affordable Care Act is the exact same thing, but some people are more likely to say that they're supportive of the Affordable Care Act just because of the language, because Obama's name is not included, and they have no idea that that's what they're doing. But it's a matter of messaging, and so um, you'll find it very interesting. And it's what's scary is that these are people who go to the polls and vote, right? And they think that Obamacare is something that's vastly different from the Affordable Care Act. It's the exact same thing. So just something I want you to think about with a taste of humor. All right. So we'll stop here. And I hope this was helpful. I think that's my last slide. I hope this was helpful for you. And Dr. Fryer, thank you for the opportunity. And if you have any questions, please feel free to reach out. Thank you.